Everyone, I think we'll make a start because it's a fairly action-packed session this morning, hopefully. So, good morning and welcome to the Drugs Research Network Scotland Knowledge Exchange event. And this was going to be on long-acting injectable buprenorphine, or LAIB. Again, we will be recording the event. As you can see, the red dot has now come up on your screens. And this will be available on the website, etc. afterwards. So on behalf of the DRNS, I'd like to welcome you to the meeting today. My name's Duncan Hill. I'm one of the, I'm the specialist pharmacist in substance misuse for NHS Lanarkshire, and I've got the pleasure of being a co-convener with Katrina for DRNS. So it's my job to do the welcome and introduction today, and then we'll go through a number of presentations, starting off with the Expo trial with Professor John Marsden from King's College London. Then we've got Lucy and Fiona, who are going to speak about the community pharmacy pilot in Grampian. Then over to Mark and Sam from Dumfries and Galloway, who are going to speak about their primary care pilot. We'll then hopefully have time for a comfort break. Again, if things are going a bit awry with timing because of the information that's coming out, we can shorten that or play about with that. After the break, we'll come back and hear about the community pharmacy pilot in NHS Lothian, followed by, from Paul and Chris, followed by Craig and Tom, who are going to tell us about what's been happening in the prisons. Hopefully then we'll just finish off with a few closing remarks in the summary. There are a few event etiquette things we'd ask you to do. Can you put your microphones on mute if you're not speaking and avoid interrupting anybody else? We found that if you turn off your video for yourself during the presentations, it helps. It boosts the signal strength, and we have got a number of people on the call today. We're expecting hopefully about 100 people on the call. Can you make sure that your name on the display is shown, or an easy identifiable term, rather than just iPad or anything else? Can you use the comments and the questions during chat or during the presentations, or use the hand raise function during the questions and answers? I'll keep an eye on the comments and questions as they come in and can relay that to the speakers during the Q&A session. And finally, the DRNS welcomes respectful, constructive criticism and healthy debate, but it does reserve the right to restrict access to events if an individual is not demonstrating usual standards of behaviour. So with all that in mind, it is my pleasure to introduce Professor John Marsden to deliver the first presentation today on the Expo trial, which has been running. John, I'm delighted to hand this over to you.
Thank you very much indeed, Duncan and colleagues. I will just ask the usual question. Sorry, just wondering why that's not going back to the beginning. Sorry, folks, I'm just going to, don't know why that did that. Let me just see if I can share my screen again. And I'll ask the usual question. Can you see that okay, please?
Yeah, looks great, John.
Yeah,
Thanks.
it's good.
Sorry about that. So, Duncan, I was just wanting to say and convey my sincere appreciation to you and colleagues at the network for this very kind invitation to present to you this morning on the results, the completed trial results from Expo. I'm going to give you a high-level talk, and I'm afraid at fairly high speed, given that I'd like to give nonetheless a broad capture of what we did, how we did it, and what we found in this study. So I'm not going to. I will gloss, unfortunately, over some aspects, and I'm sure if we have time, I'll provide some of the background detail. So the extended release pharmacotherapy for opioid use disorder study is a multi-center randomized controlled trial of long-acting injectable buprenorphine for adults with opioid use disorder. Oh, I'm not getting any, it's not advancing to the next slide on my computer, which is curious. I don't know whether it's better if I can do, I'm sorry about this, but it looks like it's not advancing at my end. I don't know whether we want to use the slides that I sent in, and I do that next slide,
I
please,
can do
Routine.
That.
Okay,
Yeah,
I'll stop. No, sorry about this, folks. It's just hanging for some reason, doesn't normally misbehave. Great, thank you. So just a couple of affiliations that you can see on this screen. And the most important perhaps is just to let you know that this was a collaboratively funded project with research costs met by the manufacturer of the product that we've been evaluating, Indivior. They also donated the investigational medicinal product, as this was not available in the UK market, still isn't. But the sponsor for the trial was King's College London and South London and Maudsley NHS Trust, and the funder had no role in the specific design of the study, nor its conduct, data collection or analysis. Next slide, please. Just to acknowledge my wonderful research team, co-investigators, I'll let you know where they hail from in a moment. We have 2 service user representatives who have tracked the trial with us and are co-authors of our products, 3 in fact, forgive me. We've got a great research team. The data was analysed at University of Bangor, both clinically and health economically. The latter I won't cover today because of time. And the trial was implemented and overseen by our clinical trials unit, and with a wonderful steering committee, as shown here for the chairs. Next slide, please. I'm talking very much to a home team and group on this occasion, but I think when I talk more broadly to people that are not familiar with our field, I think I need to set out, as we often do, don't we, the need for a particular study. And Expo, I think, fits into the literature in the context of long-standing pharmacotherapies for OUD, which have served us pretty well. Not everyone responds to them nonetheless, and globally there are concerns about retention, so many service users are not able to stay in treatment for as long as they or we would like. We know from research that there is some early non-response, and by definition perhaps that predicts continued non-response, unfortunately. And there is also non-response among people who are nonetheless retained. The Americans sometimes find that difficult to understand, but we've done some research south of the border showing reasonably concerning levels of continued drug use among people retained in treatment. So, for example, we had 1 in 7 of a large sample of people that never left opioid use disorder pharmacotherapy for 5 years, but then after a good start began to progressively lapse and continued in treatment, but continued to use illicit heroin. Next slide, please. So as we know, the context for studies like this in the LAIB space rests on our standard of care. So that's our sublingual tablet, transmucosal, or film or wafer. And that is offered to our patients in a mixture of assessment and patient preference with methadone. There's been a subdermal implant, so a depot implant, long-acting. And then we've got 2 subcutaneous LAIBs. We call them BUP-XR for extended release in the trial. I think LAIB has sort of emerged perhaps as the nomenclature more recently. 2 medicinal products, one from Camurus, the CAM 2038 designation, and one from Indivior, RBP 6000, Sublocade in some territories, and Subutex Pro is likely to be the designation in this country and in other countries in Europe. Next slide, please. So why did we think that this was worthy of study? So one of the specific reasons that we felt in the advance of running the study, of course, that this injectable offer could deliver for our patients is that it might break the cycle of perceived stigmatizing attendance for pharmacy dosing. Not everyone is upset about that, but many patients don't like it, and they cite it as reasons for discontinuing treatment and generally low treatment satisfaction. We thought that this intervention, a monthly injection, would be a simple dosing regimen for patients. We also thought we might achieve the holy grail. We might hit opioid blockade and give our patients better control of craving and to attenuate any subjective effects of lapsed opioid use, and therefore give them the control of symptoms that they would wish for. There's been quite a lot of qualitative study. We did a little small vox pop and found quite strong endorsement for patients to sign up for a trial like this. But we also felt that this wouldn't be for everyone. The fundamental misperception, missed expectation we made was that we thought our trial would be very attractive to people who were quite established in their recovery journey, and that turned out to be not the case, as I'll hopefully mention as I go. So the subdermal implant has now been discontinued. They had supply chain problems in COVID, and I think they've now pivoted to chronic pain, so that's out of the game. And we've got our two long-acting products, as I've been mentioning. RVP 6000 SubPro is under MHR review, so that's likely to join Buvidal in the UK market and elsewhere. So CAM2038 from Camurus has been found to be non-inferior to the sublingual tablet variant. But before Expo, to the best of our understanding, there was no efficacy evaluation, no head-to-head superiority trial. And we felt, for reasons that I've just alluded to, that there would be an expectation that this injection would be more effective. So we took a different path to non-inferiority. We thought it would be better, which, you know, I'm not grandstanding, but that you know, superiority trials are much better to do if you think there's a case for them. Yeah. Most people who run a non-inferiority trial generally want to argue that there is superiority when they go beyond their margins. So this is a cleaner study, and we think it's the first that's been done to our knowledge. Next slide, please. So when we do trials in my group, we want them to be really pragmatic and to map onto routine delivery of care as much as we can, even though a trial is different. There are lots of different bits of machinery going on that make it different from standard of care. But we want to make it as broadly representative of that as possible so that we've got high levels of external validity. So the interventions were our transmucosal buprenorphine or methadone, titrated for clinical effect as per normal, so nothing unusual there. The intervention was Subutex Pro, so we followed the label there, so that's the 2 loading doses of 300 mg a month apart. We actually allowed it to be 21 days because we just wanted to be as flexible as possible for people, and to be honest, we wanted to get those 2 doses in safely but as soon as we could. And that was agreed by the manufacturer in our committees. And then we had over 6 months, we then had 4 maintenance doses following the label. So either 100 milligrams or 300 milligrams, depending on preference and control of symptoms. So a patient could have 4 100 milligrams. They could have 4 300 milligram maintenance doses or some combination. They were allowed, of course, rescue sublingual buprenorphine anytime after the first dose, so that was on the map. And then the schema you can see underneath there. So we randomized 314 patients. That exceeded our 90% powered target sample. So it was a straight 1-to-1. We randomized to standard of care or to Subutex Pro. So standard of care was the patient's choice of buprenorphine, sublingual, or methadone. Of course, during the trial, they could switch from one to t'other, but it was just mapping onto that offer. We enabled patients in treatment to enroll in the study, but we only commenced screening for methadone patients when they were at 30 milligrams per day, because we didn't want to spend a long time helping people reduce from, say, 80 or above, and then find that there wasn't enough time. So we allowed people to join screening only when they were at 30. they could join at the beginning at enrollment as well. And as you might imagine, the transition process from buprenorphine sublingual to buprenorphine XR was straightforward. So we had a primary endpoint at 6 months. We looked at opioid abstinence. We had various secondary endpoints, an embedded cost utility analysis, and lots of qualitative studies as well. Next slide, please. So the study was coordinated at my centre in London, in Lambeth. We have a clinical base in Brixton, and we are affiliated with King's Health Partners, South London and Maudsley Trust, and King's College as a group. And then we worked with long-standing clinicians that we know in areas where we thought the study was needed best. So that was in the Birmingham area, in the Manchester area, the Newcastle area, and then in Dundee. So it was a study done in 5 NHS sites. There was no primary non-governmental service delivery involvement. So this is a study in the NHS. Next slide, please. So our primary outcome, we're still in a bit of a pickle in our field, aren't we? We don't have a gold standard outcome measure. Researchers are often dragged screaming when there's encouragement to use someone else's outcome measure. There's lots of kind of heat generated, and nearly all studies have their own slight variant on this. We felt that the most important measure was a count of abstinent days from opioids, illicit opioids. Now, that would give us a continuous measure of response. So you can see in that schematic, we counted abstinent days from randomization after a grace period, I'll mention that in a minute, right the way through to 6 months. So that's from week 2 to 24, from day 8 to 168. So that means our outcome measure ranges from 0 to 161 if someone was completely abstinent. And the reason we had this little grace period at the beginning followed a previous trial, actually a placebo-controlled trial of the Sublocade product in the US, where there was a logic that not counting that initial week just gave people enough time to settle in treatment, and we followed the same approach. But you'll see that I've got some captures of what happened in that first week as well as part of our sensitivity analysis. Next slide might build, I think. Thank you. Yeah, so we measured the outcome by the usual timeline follow back, structured interview. We did that at every visit. And we allowed that to be up to 90 days, which is the recall period for the timeline follow back in its maximum. We had scheduled, not random, urine drug screens at each visit. So that was up to 12 tests. And we just used the point of care immunoassay test cups. And if the UDS was positive for opioids on the day of test, we marked that and the previous 2 days as using days. And we always trumped the UDS for self-report. We've got a secondary outcome measure. I've always liked this one, which is the longest duration of continuous abstinence, as one that I think is an important measure of the patterning, if you like, of treatment outcome. And I'll show that graphically in a moment. Thank you. Next slide, please. Tons of secondaries, and I really will gloss over these because of time today, but retention, DSM-OUD and cocaine use disorder remission, craving measured by some scales, abstinence from cocaine and non-medical benzodiazepines, as I think you'd expect, and some patient-reported outcome measures, and also some clinician-reported outcome measures for improvement as well. Next slide, please. So, who took part? What did they get? Well, we opened the trial for adults. They had to have moderate severe OUD at the admission to their current episode. So the patients were enrolled at the beginning of treatment, but we could also enroll them during treatment, where given that they mapped on to what I mentioned at the beginning, they were either responding well and regarded the study as relapse prevention, or they were enrolled but perhaps not responding in the way that they would like. We converted to the injection within 7 days as planned. We excluded people only for very significant medical and psychological factors and likely imprisonment and no recent clinical history of naltrexone. Thank you. So we identified just about 1,700 people. We excluded 1,350 or so. 386 people were eligible. Most of the exclusions were for dose reasons. We identified 386 people eligible, and we randomly allocated 346. And that was 156 to our standard of care and 158 to the injection. There was a small embedded study, which I won't mention today, where we also randomized people in each arm to a psychosocial intervention. I'm afraid we put the head of that studies on the block during COVID and actually diverted all of our randomization to the head-to-head so we could hit our powered sample. So what's residual in that PSI space is a mixed methods qualitative analysis, and I won't mention it further today. Next slide, next build, please. Unremarkable sample. This is the characteristics that we nearly always get when we do our trials. So the majority white UK is self-described, majority male, 75% enrolled in maintenance OAT at study enrollment, 44% using opioids in the past week, nearly 50% using cocaine in the past week. There's a lot of cocaine in South London and Birmingham, less in Manchester, a little bit less in Newcastle, and perhaps quite a bit less in Dundee. So some site level differences. More than 1 in 5 using non-medical benzos in the last month. Not much injection relatively, so a lower level than one might see it with a purely admission sample. And then the final description is, what did they get? Well, this is really where you need to start thinking about Expo as a study of quite a good treatment already versus one that, as you'll see in a moment, has got some headroom and is quite good additionally. So the majority of people randomized to standard of care got it, as you'd expect, but 46% didn't complete follow-up, so they didn't attend for the endpoint interview, and 21% restarted treatment. That was 56 people overall, and starting and stopping is endemic for us as a field, isn't it? But then for the injection, we've got only 8 people that was allocated to the injection that didn't get it. So in spite of our best efforts to encourage them to attend for their first injection, eight folk didn't show and actually dropped out of treatment at that point and couldn't find them. 29% only didn't complete follow-up, so a much greater rate of follow-up completion, and 11% were restarted in maintenance treatment. Next slide, please. Okay, so I want to get down to business now as to what happened. So this is a little heat map of the receipt of the injection for the 158 people. So I've lined up the 6 injections sequentially, as you can see. And the black, these are actually organized by, each row is a participant, even though it's a bit blurry. But a black row is a 300 milligram injection. A blue row is a 100 milligram injection, and the gray is a missed no dose. So you can see there's a kind of bite out of the bottom, sort of stair shape, which is the proportion of people who, there's the 8 people that didn't have any injections, and then a few more that didn't have all 6. But the majority did have all 6, and you can see from the sort of color chart, almost like well over half really received the 2x300 and the 4x100 milligram injections. Thank you. So the mean number of injections was 5. 70% received all 6. The most common profile was the protocol sequence, but 11 people had 3x300 mg and then 3x100 milligram prescription profiles, and 4 had 6x300 milligrams, and as you can see, the remainder had a mixed pattern. So quite a lot of adherence, but some flexibility as we wanted to champion. Next slide, please. Okay, so let's get to business with the headlines. So this is a complicated statistical model, which I won't get into, but it's a fully adjusted model. And the adjusted mean days of abstinence from opioids is in favor of the injection compared to our standard of care. There was good abstinence in the oral arm, 105 days. but 123.4 days. These are adjusted days for a model. You'll see a much more dramatic finding in a second, statistically significant and adjusted for the design of the study. So we met our primary endpoint and delivered a statistically significant result for opioid abstinence. Next slide, please. What I want to do is just, I think this is quite dramatic, really. So I just want to highlight a little bit of the patterning of this. So this slide gives you a longitudinal course of opioid use. As with the injection heat map, this one, each row of that portrait image is a participant. So right the way from the very top all the way down to the very bottom. And I'll just take you through what each color block means. Next slide, please. So each row is data for one participant, and it's organized from day one right the way through to day 168. Okay, so it's a longitudinal map of each person in the study, and this is unadjusted. These are the real results for each person with some decision rules that I'll now summarize. So we've ordered the chart by the number of days collected data. So that decreases, as you can see. So there's a big bite at the bottom, and that gray chunk at the bottom is no data for that day. A green square is a day of opioid abstinence, and that's negative self-report and negative available UDS. A red day is a day of opioid use, so the patient either reported that they had used, let's name it, heroin, and the available UDS was also positive. And then gray is sort of missing data, essentially. And usually that's due to, excuse me, discontinuation. The keen-eyed among you, not great resolution, but can see a few bars of gray among people who were retained in treatment. So this image is for our oral participants. And you can see at the top, there's a really nice chunk of people that were continuously retained and were able to continuously abstain from heroin. And we then meet a few folk who did pretty well. They stayed in treatment, and they had a few times in which they were detected or reported as using heroin. We then enter a sort of mixed pattern with some green and red, and then I suppose there's a sort of red waistband, isn't there, in the middle, among the completely retained, but to be honest, almost completely, in some cases, non-responding, and then a mixed pattern among people who discontinued. So if you could just sort of eidetically photograph that image in your mind. The next slide, please, gives you the contrast with the injection. Oh, sorry, forgive me. So a subgroup retained and abstinent, a larger group retained but with sporadic repeating opioid use, and then a smaller group retained but stably non-responding. Next slide, please. So you can see a very different picture. This is the 158 people in the other arm. If you could just go back for a second. This is the other people in the injection arm. So you can see a larger group of people, well, a larger proportion continuously retained, so a smaller grey bite, a larger proportion of people continuously abstinent, and a larger proportion of people sporadically using, and a much thinner red waistband, if I can put it like that. So side by side, thank you. You can see a very dramatic picture. Unadjusted, the reason we have a smaller treatment effect is because of some site variation and other factors that correlate with outcome. But I think that's I have a habit of saying you don't need statistics when you've got a result like that. So just to move on briefly, thank you. Retention, we measured it in two ways. We measured the total number of days enrolled, so right the way from day 8 to 168. Oh, I should have mentioned there was no evidence of any use, particularly during the grace period. So we've got more days total enrolled in the injection arm, as you can see here. And then, thank you, we've also got a classic way of measuring retention, which is time to first exit. And so the injection group, time to first exit was pretty good for both arms, but you can see a longer retention period in favor of the injection. So if they did leave, they left a lot later than the injection arm. Next slide, please. Craving was interesting. It's interesting when you look at trials, they often just take a mean for whatever scale they're using. And what we found was that there was evidence for craving being switched off. So a lot of patients in the injection arm just said, no, I'm not experiencing any craving, no craving at all. Thanks for asking. And so this is a graph that tracks zero craving response over time, just on one of our scales, the craving experiences questionnaire. We used some VAS scales as well. And you can see that for the orange line, which is the injection, really quite a lot of improved response growing over time and higher than the oral arm. So better craving response, complete attenuation. Next slide. Thank you. And also among those people that did say, yeah, I have experienced it, there was a dimming down of the intensity, the frequency, I should say, of craving over the weeks as well. So you can see really no chance of any error bar overlap between the two arms. So a suppression of intensity in favor of the injection as well for opioid craving. Next slide, please. Very briefly, we didn't see any effect for craving attenuation off or reduced for cocaine. One of the takeaway questions for us continues to be how we can help people manage their in particular crack cocaine problem during treatment for those who are dually addicted. Thank you. Next slide. Our cocaine and benzodiazepine use. Cocaine use, not surprisingly, no difference given the profile of craving. We didn't measure benzodiazepine craving because of burden, but you can see no difference in favor of the intervention group for either of those measures. Similarly collected by timeline followback and UDS for the primary. So no difference, no impact on cocaine and non-medical benzodiazepine use. Next slide, please. And then I hope I don't sort of skim too superficially over this. We hold very dear our assessments of patient reported outcome, and we also think it's important to assess clinician reported outcomes. At my center, we developed a service user recovery evaluation. There are many of these, but they capture patient specific endorsed measures that are recovery reflecting. Relationships, resources, drug use, outlook, self-care. Those are the domains in the SURE. And we've got an effect of increased SURE response to increase patient-related subjective recovery, albeit within 6 months, but in favor of the injection. We also asked our patients to just simply say, look, are you better or worse? You know, classic 7-point rating scale. Large odds in favor of the intervention. And we asked the clinicians the same question, and they actually rated patients in the injection even more improved than the patients themselves. Thank you. Next slide. DSM-5, I always regard it as very important to capture DSM remission and relapse criteria. It's not a patient-centered approach. It's a dispassionate diagnostic workup, of course, but important for characterization. And we've got some capture of early remission status for at least 3 months in the endpoint. We've also got a study in which we're looking at longer term outcomes for a subset. Next slide. And we've got the effect, thank you, of more early remission diagnosis for people in the injection arm compared to standard of care, although standard of care looks pretty good, doesn't it? So we've got this headroom I keep on alluding to, but a statistically significant finding in favor of the injection. And then next slide, please. So just to summarize, I hope I haven't overstayed my welcome this morning, Duncan and co, forgive me if I have. What do we take from this study? I've given you high level findings. We've got a manuscript that's going to be also capturing our health economic findings, and that will be submitted for peer review for publication in a journal very shortly. But we conclude that the Subutex Pro injection is superior to the standard of care as defined in our study. It achieved more abstinence. There was better retention and better total time enrolled in treatment. There was greater likelihood of attaining early remission from OUD. There was quite dramatic improvement in craving control for opioids, but not for cocaine. and there was more evidence from the patient and clinicians' perspectives for improvement and recovery. Certainly, we haven't found any impact that cocaine or cocaine use is impacted by offering patients this injection. I can hear you saying, well, why would there be? And you know, it sets up for me the next trial in which we can put everyone who's dually addicted onto the injection and then randomized to a cocaine medicine, of which we've got several targets in preparation. And no significant impact on benzodiazepine use, something that is of course of high concern to you guys in the network. So we think in taken together, the evidence is that this injection is simple and acceptable. It's an effective option for OUD symptom control. Nevertheless, the battle continues to find adjunctive medications and psychosocial interventions and novel pharmacotherapies, indeed, to attenuate cocaine and non-medical benzodiazepine use in this population. And I think there's also a really rich study theme in play now to look at the use of Subutex Pro as a maintenance to taper intervention. We've actually enabled patients to stay up to 2.5 years on the injection for an exploratory study. But we don't know how many injections are needed. The answer, of course, is as many as someone wants, but the possibility of a very effective taper where the person is able to have a very smooth glide path down to abstinence with just an injection that they don't have to worry about daily taking of medication looks like a very useful horizon for study coming up close now. And on that note, I'll end the next slide just to go, boom, thank you very much. A protocol is here for those of interest. We'll be publishing the study hopefully in the early summer.
Thank you, John. That was a very in-depth and fascinating presentation. And I'm sure there are lots of